mental health consequences in COVID-19 session. I'd like to introduce Dr. Jeffrey Stovall. He is an associate professor of psychiatry at Vanderbilt University Medical Center in Nashville, Tennessee in the United States. Dr. Stovall works in community psychiatry and in primary medical settings with an emphasis on serious mental illness, the integration of psychiatric and medical care, and cross-cultural psychiatry. Before I pass it along, I would just like to say if you have any questions throughout the session, please put them in the chat box. We will be spending some time at the end on questions and answers with Dr. Stovall. And with that, I will pass it along to you, Doctor.
Thank you very much to start with for inviting me to participate with you all. I hope this is a useful session for you. And I appreciate your devoting some time this morning to discussing and talking about the mental health consequences of COVID-19. I would give probably 15-minute or so presentation, but really wanted to devote a fair amount of time to your questions and discussions that would follow. Next slide, please. Every year here at Vanderbilt, I teach a course on global mental health, and the students are always grappling with what that means. What's the concept that we're trying to discuss? I have here a definition from the U.S. Department of National Institute for Mental Health, but I think we've all seen now in the context of this pandemic that global health has taken on a very real meaning for all of us. And global mental health in response to this pandemic is something that we're all beginning to get some understanding of as we experience it every day. Next slide, please. So let's think a little bit about those individuals who are at risk of being infected with COVID-19 and how that is already connecting to those with high rates of pre-existing mental illness. We know that certain populations are at greater risk of being infected. The elderly, those with lowered immune systems, those living in crowded or poverty-defined areas, those with addictions. Already we know that those individuals are at high rates of being infected with COVID-19. So as we start talking about the mental health consequences, let's initially think about the population that may be infected. I'm going to talk a little bit later and want to spend some time talking about healthcare providers because we as healthcare providers are also those at both increased risk of being infected and at risk of carrying pre-existing mental or emotional distress even prior to COVID-19. Next slide, please. So what do we know? What are the mental health consequences that we know for individuals infected with COVID-19 as we think about the direct impact upon the brain or the consequences of our treatment for COVID-19 infection? Throughout this, I'll comment upon things we don't know. This is obviously a new illness as we're coming to understand it. The consequences short-term are just now being understood. Long-term consequences we don't have any idea about as the pandemic unfolds. Some of the information that I'm going to discuss is related to what we've learned from previous coronavirus epidemics and pandemics, and some we've learned from consequences of other disasters, primarily natural disasters, earthquakes, and such. So what do we know about the direct impact upon the brain? The most common thing that we're seeing among those infected, particularly with more serious infections that lead to hospitalizations, is the presence of delirium. And a period of delirium is present in about 2/3 of individuals who are more seriously infected and are symptomatic. In ways we're just now coming to understand, COVID-19 has an effect upon blood clotting and a significant increase in cerebrovascular disease in individuals who are symptomatic with COVID-19. Even in people who don't have more serious consequences, milder symptoms, neurologic symptoms are frequently present. Headaches, dizziness, and some cognitive dulling, cognitive impairment. And that cognitive impact is something we're seeing kind of across the board, and maybe something we begin to see as a longer term consequence that will have a functional impact upon individuals. Next slide, please. So what about the mental health consequences for those individuals infected with COVID-19, looking more at the psychological impact of the illness? And this is where we do have information from previous coronavirus infections over the years. Looking at data that looks at this population a year post infection, we'd like to think a year post recovery. 29% have been shown to still have periods and episodes of depression 1 year after recovery. Anxiety remains significant in about a third of those individuals, and symptoms consistent with post-traumatic stress disorder and its functional impairment are still present 1 year out. So 1 year post-recovery from infection, people still have an impact. As I said before, cognitive impairment seems to be one of those more lasting effects, as people show declines in memory, attention, concentration, and the speed with which we process information. And even some of the early studies with those infected with COVID-19 have shown that persistence of cognitive impairment. Again, this is not something that in large numbers we've been able to look at with this new pandemic, and we're extrapolating from what we've known in other populations. Next slide, please. So what about the mental health consequences for individuals living in the community who don't have known infections? These are not people who have become ill. These are not people who end up hospitalized, but rather individuals who are living amidst the pandemic. And there we see and know about the consequences of social isolation. Clearly, in most communities in the world, the rules, the advocacy has been around sort of a social withdrawal, a social distancing. And we know that in and of itself has a direct impact upon mental health. 47% of those sheltering in place report adverse mental health effects simply from that sheltering in place and that isolation. We know well the long-term impact of the economic impact, job loss, income loss, as the world economy has slowed. And we know that 50% of those people who face that immediate job loss have a negative mental health impact. We well know that those individuals are going to face increased risks of depression, anxiety, suicide rates go up, substance use and addiction rates go up following a job loss. So we see this widespread just among the general population of people who aren't infected. Next slide, please. So what can we do about that? And this is a slide that I'll repeat a couple times, and to some degree, we're working in a world that we don't know in terms of the widespread effect of a pandemic. And there are really a lot of broader societal and economic issues that we as physicians don't have much control over, or have little control over. But we do have a role as physicians in educating, in advocacy, and in at least having discussions around prevention and treatment in ways that we've not had to face before. So what can we do? Part of it is just increasing our own level of awareness and the community's level of awareness, being able to recognize and provide prompt treatment when we see those consequences develop, providing education in large part with awareness, attacking the stigma that can be associated with mental health and mental illness, stigma that may exist in the community, stigma that may exist within healthcare systems, and stigma that may exist among ourselves and our colleagues. Next slide, please. One group that we are just now beginning to see the impact of COVID-19 on is that group of individuals who have pre-existing mental illness. Epidemiologic studies in the United States show that upwards of 20% of individuals at some point in their adult life will meet the criteria for a diagnosed mental illness. Most of those people, many of those people are in states of recovery, though many also have a more chronic relapsing course to their illness. We don't know the impact of a widespread disaster of a pandemic upon these individuals, though already we're seeing elevated rates of relapse among people with chronic psychiatric illnesses. That may be due to the level of stress and that impact. It may be difficulty accessing care. It may be people have taken to the extreme the idea of I need to socially isolate, I need to socially withdraw, cutting themselves off from support they might normally have, not going to the pharmacy to get their medicine, not going to their regularly scheduled appointments. But we're definitely seeing relapses among those with depression, with psychosis, those with addictions, and we would expect to see this extending in coming months. Next slide, please. So again, what can we do? Same concepts of being aware of this, being aware that these are populations at great risk of relapse. If we're involved in that treatment now, trying to maintain greater risk. And again, directly addressing the stigma that those with psychiatric illnesses or those who are treating people with psychiatric illnesses, directly addressing that stigma that may exist. Next slide, please. So let's focus a little bit on the consequences of clinical personnel, of healthcare providers who are working with patients with COVID-19. All those risk factors that I already mentioned affect all of us. We're living and working in a high stress environment. We and our families are socially isolating. We are experiencing much higher rates of COVID infection than our other parts of the population. So we ourselves may have pre-existing depression, anxiety, substance use disorders. So we are like our patients in some ways, but have unique issues that we're confronting. I want to talk a little bit more and open to questions about the experience we all have in fearing our own infection, fearing that we may carry COVID-19 home to our families, that we may end up treating a colleague who has become infected. That level of guilt, that level of anxiety, that level of fear is something that is unique in some ways to healthcare providers and has a unique impact. We do have a little bit of information from a good study, and I'll have a bibliography at the end that will cite this study. But an early study looking at healthcare providers in Wuhan early in the course of the pandemic showed some startling results where 50% of healthcare providers were showing marked signs of depression. Close to 50%, 44% were showing signs of anxiety. Insomnia was present in about a third of that population. And almost 3/4, 71%, identified a global sense of distress that was having functional impairment. Of note, the rates were much higher, significantly higher among women than men. And perhaps not surprising, the higher rates were shown in those who are more in frontline roles, so more directly working with individuals with COVID-19 infection, perhaps having more constant exposure to those individuals, working more closely with them. and in our own settings to be aware of those individuals being particularly high rates of having mental health consequences. Next slide, please. So again, what do we know from other studies in the past? And most of these studies have been on isolated areas, isolated healthcare populations, usually post-disaster. Again, a disaster that may be a one-time event of an earthquake, let's say. Not an ongoing event as we're seeing in terms of the pandemic, not as widespread. So there likely are differences when it's one community that's affected versus really, the entire world affected. But what do we know from that already from previous disasters? Studies have looked at those individuals, those healthcare providers, up to 4 years after the event, after the disaster, and remarkable findings of about a third, 33% of those healthcare providers still 4 years out, still meet criteria for depression. Same population, same number, about a third, still with significant symptoms of anxiety. Insomnia seems to be a persisting issue for those individuals. And again, we see this persistent impairment of cognition in those individuals. Next slide, please. So again, what can we do? As a starting point, I think we have to recognize as physicians that we're not very good at admitting or acknowledging the mental health consequences, the emotional consequences of what we do every day. And part of a starting point is just to acknowledge that we do have that consequence that we have to deal with. We also have to recognize that often our role with other healthcare providers is physicians, is in a more leadership role. Part of that leadership role may be our own projection of being invincible, of our colleagues looking at us as individuals who may be unfazed by what we do, and they may look to us for some strength, if you will, of carrying out their roles every day. This is really going to require for us and for our teams an acknowledgement of the toll that this work can take and some ability to both address that stigma again, but be sure that we are taking care of ourselves and taking care of our teammates. So again, being aware of this risk, being aware of these numbers that I'm talking about, being willing and able to accept prompt treatment if that's required. Again, talking about the stigma, or acknowledging the stigma that comes with an emotional issue, a mental health issue. Thinking about self-care and team care, and we can talk about this a little bit in the question and answers. And again, to our ability to advocate for our own well-being and for the well-being of our teammates and colleagues in those settings where that's appropriate. Next slide, please. So if we expect that up to a third of the population in 4 years will still be having consequences, is there anything we can do about it? As physicians, we often like to focus and prefer to focus on prevention than treatment. We know that prevention can go a lot further. This is not something that immediately we've been able to prevent. We can think in terms of prevention that we can do at this point, but again, what can we do in the moment? What we know from other disasters, what we know from studies of military personnel is the importance of returning to normalcy. Well, we don't know what that is right now. People are still isolated, economies are still struggling, communities are still struggling. So it's hard to say if that's possible right now. We have learned, and we clearly know, the existence of relying upon existing social supports, family, community, religious faith and religious organizations, one's colleagues. Again, something that has been tremendously disrupted by the imposition of social distancing, of physical distancing. So the very things we're doing as protection clearly add to these consequences. I can't stress enough the importance of focusing upon the risks of substance use. I have here that alcohol does not heal. As we think about some of the consequences, insomnia, stress, poor sleep, we can see that reliance upon alcohol or other drugs of abuse can be a first step for lots of people, but as we know, as healthcare providers, it has longer-term consequences that will be counterproductive. The importance of focusing upon sleep for our own protection and our own healing, as well as that of our patients, is important and may be related to some of the longer-term cognitive dulling that we see. This is a time for an effective use of sleep medications as they're available, and a focus on sleep hygiene through some of the cognitive behavioral treatments of insomnia. At the end of this, there's a slide that lists some apps that can be available depending on your access to those, and some of those have been shown to be incredibly helpful for sleep. So effective treatments really are effective. We know the effectiveness of antidepressants in treating long-term depression and anxiety. As healthcare providers, it's up to us to know what might be available in our countries and what might be available to our patients, and know how to use some of those. And where available, we know that psychotherapy can be incredibly helpful for anxiety and depression, as well as sleep. And again, I've listed some apps at the end of this presentation. Next slide, please. So again, just a reminder that effective treatments really do help. The role of antidepressants, the role short-term of anxiolytics, whether that may be benzodiazepines or antihistamines that you have available for your use, know what's available for your patients and how to use them. And again, the role of psychotherapy in that preventing some of those long-term consequences we know could be helpful. Next slide. So I just have listed 3 articles here. The last one, number 3, is the one that focuses upon the effects on Wuhan, healthcare providers in Wuhan, and is particularly useful in, I think, opening our eyes in terms of the consequences. And the second one gives a nice review of psychiatric and neuropsychiatric presentations and effects of coronavirus infections. So with that, I want to stop in terms of formal presentation, but really wanted to get more into your questions and see if we can have some discussion going forward. Here are the web-based, the web-based resources. The first 2 really focus more on sleep. The other 3 give resources around anxiety and depression and can be extremely helpful either for our own use or for use by our patients or our colleagues. So I'm open to questions at this point.
Great. Thank you so much, Dr. Stovall. That was really interesting. And I'm going to kick it off with some questions that we received in registration. And then hopefully, again, we're encouraging everyone to please ask some questions in the chat function. We know everyone is muted due to Zoom security, but we will absolutely address your questions if you type them into the chat function. So Dr. Stovall, you talked about a few of these questions, at a high level, but just digging in a little bit deeper into them from the questions we received. So how would you maybe define, I guess, the psychiatric manifestations of COVID-19 or ways to tell if someone is having mental health, affectedness from COVID-19? How can I, as a clinician, diagnose it, whether that's both, I guess, in an individual patient that comes in and also in my staff if they're burnt out or if they're having, a mental health crisis due to this?
Sure. And I think what a lot of this may relate to is the effects of, as we go from sort of immediate fear, that fight or flight response that we all have, And as we've seen in our communities and our patients, the immediate fear as some understanding of this pandemic grew. And as that kind of acute response shifts into a more chronic response, a more chronic anxiety, is I think where we're seeing some of these mental health consequences. So among our colleagues, among ourselves, or our patients, often people will be describing sleep disturbances. I think that's something that is frequently recognized. While it may show up with all sorts of somatic complaints, fatigue is common, and then at some point the frank symptoms of depression, of sadness, of not eating, not taking care of oneself, and not to minimize the risk of the development of suicidal thoughts or suicidal plans ultimately. I think, as I mentioned some of those, most of us are probably thinking, well, I'm already fatigued and I'm already not sleeping well because I'm working longer shifts. My colleagues are out. And so I think it's hard, or it's important to be attentive to what's beyond the norm, knowing that we're in sort of a new norm.
Absolutely, thank you. And what advice do you have for hospital administrators to best help us as healthcare workers address mental health issues in our institutions?
Well, clearly, and you all know from your own institutions, hospitals and hospital administrators have struggled being able to provide the basics for healthcare providers and for patients. Have struggled to provide the basics in terms of PPEs and other treatments that are necessary. So for many administrators then saying, okay, well, there's something else we need to pay attention to, maybe more than they can handle. But I think it's an important role that we as physicians and healthcare providers can play in those institutions to say, okay, yes, we need that equipment to do our job today, but this is what we know, and this is what we should expect. This is what you need to expect among your hospital staff a week from now, a month from now, a year from now. And in order to take care of our patient tomorrow, we have to be able to take care of ourselves today. And I think that may be a role we can play in advocating for our own well-being, but the well-being of our teammates and our colleagues.
Great. And in a low resource setting, if someone doesn't necessarily have access to some of the medications or the apps that you suggested, are there alternative options for coping mechanisms?
Yeah, I think a starting point for everybody is the role of sleep. Sleep as a restorative thing that doesn't necessarily require apps, doesn't necessarily require medications. And the ability to try to restore the sort of social connections and social supports that we know can be helpful. Again, there are challenges with each of those. But even in fairly resource limited settings, some basic medications may be available. So the use of antihistamines, for example, short-term for anxiety, for sleep, may be available. Some of the older antidepressants may be available. But again, those resources may be limited places. In general, thinking about the concept of self-care, both in terms of what we teach our patients, but in terms of how we take care of ourselves, is crucial. And by self-care, I mean taking those moments to be sure we're still going forward. By that, I mean even taking the time to eat on a regular basis, taking the time to go to the bathroom on a regular basis, taking the time to drink water on a regular basis. Basic things that get lost in what may be a hectic or intense period of time. We may only need a few minutes, or the ability to take a few minutes throughout our day to have some quiet, to step outside, to take a deep breath, to talk to our colleagues and acknowledge the stress that we're all under. We may all think, well, I don't have time to even do that. But again, if we're thinking of what can I do today that's going to help me to still be working tomorrow, investing small amounts of time to take care of ourselves is not being selfish. It's not taking us away from treating a patient. Rather, it's preparing us to keep doing that.
Great, thank you. Do you have suggestions or resources that you could point people to for counseling in the now corona positive families and or bereavement counseling?
Yeah, again, I think I would look at some of those apps. I think particularly there's one, I forget what its title is, but it is Canada in the title. That has links to a number of other apps that may be helpful, particularly for families and for grief counseling, if you will. I want to acknowledge in this one of the other difficulties or perhaps even unique experiences that we're all having is the absence of usual supports for someone who is dying or for families who've lost a family member. Families are not as readily present with their family members who are hospitalized, who are dying. Families are not able to rely upon the usual ways of grieving, whether that's rituals around death, rituals around burial, or rituals around support. We probably all know in our own experiences that the death of a family member is often an opportunity for families to get together and grieve together, to talk, to support each other. Well, we can't do that as readily, or we're even prohibited from doing that. And we don't know the consequences of that, but we know it's a disruption of the usual ways that we grieve in a healthy way. In terms of being healthcare providers, that's also adding an additional role, and an incredibly stressful role for all of us, which is serving as surrogate, if you will, family members for that patient who's dying, and sort of translating our experiences to the family members who may not be able to be there at bedside as they might otherwise be with a dying family member. That's not something we're necessarily all trained to do. That's not something about we generally want to take the time to do or have taken the time to do, but certainly a new role for all of us.
Great. And yeah, I mean, that's definitely a tough topic. And we have the link now in the chat for anxietycanada.com. We will make sure that that goes out in the follow-up email to everyone. Good question that just came in the chat box. Is there any specificities for adolescents? How do we ensure that healthcare providers are taking into account the specific needs of adolescents? And I'll throw in children there as well.
Sure. I think we don't know fully the support and really how healthy the environments can be in schools. I think we all know that schools provide more than just what's in the textbooks. Clearly, what's in the textbooks is important, but I think we know in many of our communities, schools provide social support throughout the day for children. May provide meals for children, may be a place where children are able to access healthcare. So in most communities where schools may have been shut for a period of time and may remain shut, we don't know those consequences. But children, while we think of as resilient, we don't know what those consequences will be long term. So I think, again, we get to the point of awareness and in our own practices, being attentive to what's going on in the entire family. We can imagine the level of anxiety that children may hold as they worry about themselves, as they worry about their family members, as they grapple to understand something that as parents we may not be able to explain in the usual ways we explain things to our children because of our own levels of anxiety, our own levels of uncertainty. So I think again, it's a question of awareness, of education, of even outreach, and realizing that children and adolescents, while resilient, are going to have long-term impacts from this as well.
Yeah, absolutely. And what about pregnant women, lactating mothers, those mothers going through delivery, or families going through delivery during this pandemic? How can healthcare providers help relieve the stress and mental health, you know, I guess, post problems that may arise in those populations?
Sure. And I believe in the series, one of the earlier weeks, you had a lecture led by an obstetrician who talked about the particulars of concerns around COVID infections among women who are pregnant. So I won't get into that. I'm certainly not an expert in that area. But again, I think what we can be aware of and can acknowledge is this is stressful and worrisome for everybody, but certain parts of our population will be more worried and more stressed and more anxious about this. That's where I think the elderly may be or are under unique pressures. People with other chronic illnesses are under unique pressures and worries. Pregnant women, I think, would fall in that category of individuals who feel vulnerable for themselves as well as feeling vulnerable for their child. And those worries of, will I infect my baby? Can I get access to those traditional supports? You know, my mother, my aunt, and others who would usually come and help take care of me and the baby for the first period of time after I get home or after the baby's born. Well, they can't do that now. So you have an individual who is under usual stress of having a baby, increased stress and worry because of COVID-19, and then again, not being able to rely upon the traditional sources of support. And again, it's a lot of being aware, of educating, of asking our patients, of talking to our patients about that, but knowing that we may have limited abilities to have an influence on that at the moment.
Great. What are your recommendations for the mental health consequences we encounter because we worry about not having enough or the proper type of PPE when we treat COVID-19 patients?
Sure, I think that's one of the huge impacts upon us as healthcare providers. And that fact of not having the resources that we all know are what we need. This is the textbook way that we would practice medicine. This is the textbook way that we would treat this patient. And we're then being asked to do something that's not textbook, that we know is not the right way to do this. So for many of us, that makes us angry. For many of us, that adds to our level of anxiety. Well, you know, I'm supposed to use this kind of mask when I do this to protect myself. Well, I don't have that mask. So what does that mean? How much is that increasing my risk of becoming ill? How much is that increasing the risk that when I go home at the end of my shift, that I will get my family sick? And, you know, again, beginning to kind of stay stirred up in that way. That's part of what, for healthcare providers, leads to those increased rates of depression, of anxiety, of substance use, and of isolation. Certainly reports of healthcare providers who aren't going home at the end of their shifts. They're staying elsewhere, staying even more isolated from their families. So part of it is being aware of this. Part of this is educating ourselves in terms of, well, what can I do? I think there's been a remarkable display of resiliency among healthcare providers in innovating and, you know, developing the safest ways that we can do things. But again, rates of infection among healthcare providers, rates are much higher than the general population. And often it's because of this lack of resources to do things safely.
And you just touched on this a little bit, but what advice do you have for healthcare workers and their families who are afraid that they will bring COVID-19 home? Do you recommend that we self-isolate, and what impact would that have on our mental health?
Sure. I think families of physicians always have a unique relationship with that family member who's a physician. Often we try the patience of our family members by working long hours or being on call or a variety of different things. Or family members are often aware that we may be in situations where we put ourselves at higher risk, throughout the years. And I think family members often suppress that or don't really talk about that because that's, they're part of a doctor's family. Clearly, this is a very unique situation. And I think where do we go from there with our families? I don't know that studies have shown what the right way to go about isolating the risk from our families. I certainly know that many healthcare providers, I dress differently now than I usually do at work, and when I go home, I change clothes in the hallway just as I come in and wash my clothes. Things I didn't normally do for over the years. I think part of it is acknowledging our family's anxiety and having frank discussions about that with our spouses, with our family members, acknowledging their own stress that they're under and being tolerant of the stress that they're under as well. And again, taking care of ourselves and assuring our families that we are doing all we can to take care of ourselves, whatever that may be in our certain situation. But again, this is one of the things that is probably most burdensome for physicians and their families during this period.
Yeah, absolutely. And what advice do you have for those healthcare providers who need to make difficult choices about which patients get treatment, for example, if there aren't enough ventilators or enough medications available in a hospital, and the choices are very difficult? Do you have recommendations for how to deal with those types of decisions and I guess the aftermath of feelings on making those decisions?
Sure. Again, all of us have had different experiences at times when resources are more limited. But as physicians, choosing who we will treat and who we won't treat is not the usual way that we approach our work. Is not the usual way that we've been trained and educated, where we want to help everybody and we look at each life as being equal. And now we may feel as though, or may even frankly be put in situations of making those decisions. What can be protective in that? Sometimes that's where sort of somebody else setting some rules, whether that's your healthcare system, your hospital, your clinic, your team, coming up with sort of a joint decision. And this is then what we apply. If we have to apply those triage decisions, this is what we're doing. So we're not having to make that individual decision in quite the same way. May help us both more clearly make a decision, but help us wash some of the guilt that we will experience in doing that. Our ability to participate in drawing up those guidelines or in those discussions is important when that's available, but that we often don't have that role. Again, as physicians working with medical teams, it's important to, again, show that leadership with our teammates and colleagues and acknowledge that we're put in new situations, acknowledge the difficulty we're all having in dealing with this, acknowledging what may be very unique situations and decisions we're having to participate in.
Thank you. A few just came in through the chat that I'll go through. From Nata Health Center, how do you talk to someone who is alcoholic dependent if they are, I guess, assuming that alcohol will cure them? So how do you kind of get them off that path?
Yeah, I think part of it that we as healthcare providers, as physicians, can often serve as sort of a dispassionate educator, is just tell them what we know. You know, this is what we know about alcohol, which is that, yes, if you drink tonight, you may fall asleep more easily, but we know that alcohol disrupts the natural sleep patterns, and we know that over time that's going to work against you. We know that you may fall asleep, but you may wake up earlier. We know that if you've had drinks, you're more likely to get into an argument with a family member. We know that you're less likely to be able to be there and be supportive for a family member, for your child who's distressed. So part of it is just very frank discussions, again, dispassionately, but in our role as educator, if you will, with our patients. And then it's often helpful to help somebody see the consequences of that. Yes, there may be positive consequences, but what might be negative consequences? And then again, to empathically acknowledge why they may be drinking. So yes, they are anxious. Yes, they're not sleeping. Yes, they're feeling angry or guilty about something. Acknowledge that and try to help them think of, okay, what else can we do other than alcohol? In this case, what else can we do that might relieve that may address that, that won't have the negative consequences?
Great, thank you. That's helpful. And from Bukova Regional Referral Hospital, in case a patient does not or cannot recover from these mentioned conditions and it leads to psychosis, what advice or treatment can be given to the patient?
So that's an interesting question. And I think that's part of some of the longer term consequences we don't yet know. I've certainly seen the development of psychosis in patients who have pre-existing psychotic disorders. So that's the population I primarily work with, people with schizophrenia in particular, and the relapses that are occurring among them. In terms of individuals who've not had psychosis before, I think early with the pandemic and in treatment, there was perhaps some use of steroids to treat some of the respiratory symptoms people were having. I don't know that that's so widespread now, but certainly we know from steroid use that psychosis can be a consequence of that. So part of it is looking at kind of what's underlying it. Is it really more of a delirium because they're having more acute symptoms that we need to manage? Is it related to medications we may be using? But I think what we will be seeing is people developing psychosis where we haven't seen that before. That's probably going to be related to symptoms of depression and anxiety. And again, the ability to get in there and try to treat in whatever resources we have, whatever medications we may have. But to look at that again as a consequence of the pandemic, if not even a consequence of the infection itself.
Great, and one that came in from Priscilla Jumbo, going back to substance abuse. During lockdown, it's been reported that there is an increase in consumption of alcoholic beverages. Do you think that this is an indicator of an increased prevalence of substance abuse, that the increased prevalence is likely going to be another long-term effect of this pandemic?
Sure, I think that's a good point. And you know, we can approach that many different ways. We can look at it as, you know, I sometimes wonder to what degree is this a predatory effect by manufacturers of alcohol, of bars and liquor stores and the like that have pushed that. Certainly in my experience of knowing that as there's been lockdown of businesses in my community, liquor stores have still delivered, have still stayed open, still advertised on television and other places. So one can take a more cynical view in that way. But we also know that alcohol is something that people use to treat anxiety, to treat insomnia to treat that level of distress they may be experiencing. And we know that most people can drink small quantities of alcohol without a significant impact. But we do know that there's always a subpopulation of those individuals who, once they start drinking alcohol, will go on to develop substance abuse problems over time. So clearly that's going to be an issue of people who are developing addictions who did not have them before. And again, periods like this, stressful times, are times when people who've had an addiction that's been in remission are much more likely to relapse. While those supports that they've used to stay sober, whether that's a formal treatment or Alcoholics Anonymous, or their social supports, their church, their family, while those supports are disrupted.
I do have a few more questions, and we started late. So Dr. Stovall, do you have another 5 or 7 minutes to?
Yeah, I have another 5 minutes or so. That'd be great.
Okay, great. So in many contexts, having COVID-19 can be stigmatizing. How can individuals and families being stigmatized by this diagnosis be supported?
Sure. We'd like to say we would be able to, again, use education. You know, if we were able to say, yes, once somebody has been infected and recovered, then they're immune, they aren't going to pass it on. I think that's part of what we're just now coming to understand. We don't understand the degree to which people develop antibodies. We don't fully understand what that development means in terms of their ability. Can they still get infected again? So some of those issues around stigma we can't address directly. Certainly in communities, healthcare providers have been applauded for our work, but in some community, healthcare providers are looked at as risky. Are we carriers of the virus? Might we be infecting people? And then by extension, that same impact upon our families, or that same stigma against our families. So again, I think we educate to the degree that we can. We tell people what we know. We address those rumors. We address those false claims that are out there. And we acknowledge that some things we just don't know. Tomorrow we may know, but today we may not know the answer to some of those.
And do you think, in your opinion, do you think COVID-19 patients and their families should be screened for mental health issues before discharge? And if so, what tools or checklists are available?
Sure, good question. And I think in terms of kind of the immediate time when you may be discharging somebody from the hospital, there's probably enough other things to focus on. But I think we are clearly seeing that in the weeks and we'll see in the months after infection is when those rates of depression, when those rates of anxiety, when those rates of substance abuse are going to be more prevalent. There are some basic screening tools, the PHQ-9, for example, which is 9 questions that screens for depression and anxiety. Those are easily administered tools to use and can be used in more widespread settings. But simply as physicians asking those questions of, are you depressed? Are you anxious? How are you sleeping? Are you drinking alcohol? Are you having suicidal thoughts? Those basic questions can often be enough to identify somebody certainly at risk, if not clearly suffering from an illness at the moment. And again, bearing in mind that 1/3 plus of the patients we see will have those consequences.
Great, thank you. So I'm going to wrap it up, but I do want to ask you for some closing comments. And in that, if you could just kind of help us with the top 3 actions you would recommend that we take as healthcare workers to protect our mental health as best we can.
Yeah, I think, again, I want to thank everybody for inviting me to be part of this. And acknowledge that what we are doing and what we're being asked to do now is extraordinary. For some of you, you may say, well, yes, and 2 years ago I was asked to do something else extraordinary, and tomorrow be asked to do a third thing. It may be the nature of our work and certainly the nature of some of our healthcare settings, but to acknowledge that right now our work is putting extraordinary demands upon us when we may have less resources than we might usually have, or even new experiences of not having adequate resources. To acknowledge that. So where do we go from here? Where are kind of the top 3 things to do? I mentioned some of the basic self-care things that we can do, whether it's around sleep or relaxation or what we might call centering ourselves on a frequent basis, taking care of our basic needs, using those supports that are available to us, and those supports, at work really need to be focusing on our teams that we may work with. It may be a small team, it may be a large team, it may be other physicians, it may be nurses, it may be other healthcare providers, but acknowledging to ourselves and them that we are sort of all in this together and we are facing unique challenges. And finally, being able to acknowledge and seek help, something that we as physicians are not very good at doing, but to seek help at times when that's become too extreme. When we aren't sleeping anymore, when we feel like our depression and our anxiety is getting in the way of our work, if we find ourselves drinking more alcohol, if we find ourselves feeling suicidal. And there was a celebrated case, or acknowledged case here in New York recently, where the head of one of the emergency rooms in New York that had been facing high levels of infections and lack of resources. She committed suicide, acknowledging to her family that she couldn't take it anymore. So being aware of the risks that we face, and again, being able to seek help when that's necessary, and to listen to our teammates or our families who may notice that or acknowledge that in us before we do.
Okay, thank you. Thank you very much for this very enlightening session. I think it was very helpful for everyone here. It's not so often that we get to talk mental health, and it's a really, really important topic. So Dr. Stovall, thank you very much. And I will pass it along to my colleague Claire to discuss how we can continue this conversation going forward.
And I'm gonna go ahead and sign off, but again, thank you, and I will be available through the WhatsApp chat going forward if people have other questions I didn't get to today. Thank you.
Thank you, Dr. Stovall.
Yeah, thanks, Dr. Stovall, and thanks, Monica. So everyone, we have a WhatsApp group which you can join by scanning the QR code on your screen. We've also sent out the link through email if we have your email address. I want to acknowledge that the WhatsApp group may be full. I think we may have hit our limit of participants in the WhatsApp group. So if you're in the group, or if you're able to join the group, you can ask your questions there. But if you're not able to join, you can always ask us questions through email. Our email address is echo@assistinternational.org. We'll also be posting this session recording and the slides and some other resources, some of the apps that Dr. Stovall mentioned. We'll post all of that information on our website so that you can refer to it and use it as a resource. Thanks.
Thank you, Claire. And I just wanted to mention, lastly, we do have a short poll we're going to post now. Hopefully you can all fill this out. This is going to be really helpful for us to continue our sessions. And I will mention, thank you for everyone joining our session today. Thank you to the Vanderbilt University Medical Center team, to GE Foundation for making this possible, and again to Dr. Stovall for the presentation today. Again, please fill out this poll. We will leave it up for the next few minutes. Please connect with us via the WhatsApp group or Assist International or the Vanderbilt team. We'll be sending out a follow-up email with a lot of information to all of you. And we are hosting an oxygen therapy series every Wednesday at 4 p.m. EAT or 9 a.m. Eastern Standard Time. That will be happening for the next 5 weeks on Wednesdays. If you're interested, we will be sending out invitations for that. So again, thank you very much, and we will keep up the poll for the next 2 to 3 minutes.